back to manual muscle testing. Forget it. It is just impossible to attribute any one motion to any one muscle of the thumb, except perhaps the rotation. When you put that toothpick on the fingernail, you know then that that is the opponent's pollicis. But other than that, you really need to think about now looking at groups of muscles and what they do. Because it's impossible to pick just one out, because it's not just contracting. Contracting is part of a group. And remember, manual muscle testing was really created for much larger muscle groups. It was to determine whether or not you had polio, which is a pretty important decision maker. But it really does not lend the principles of manual muscle testing do not lend itself well to really small muscles, particularly when they cross multiple joints. So I just don't think it's practical in the thumb. You test motions rather than individual muscles. And I would direct you to the work that Bronsma and Schroeder's have done on this subject, because I think they've really hit the nail on the head. So palmar abduction, which is your median nerve, can you get your thumb out of your palm? That's a very easy one. Does your thumb rotate? That's not just the opponent's pollicis, remember, because you're looking at the thumb, and the opponent's pollicis only does the CMC joint. So you're looking at the entire group, including the abductor. Does the MP joint flex? It's not just the FPV. In my way of thinking, it would be entirely dependent upon what the specific injury was. Okay, for example, let's take that it was an FPL injury, for example. You're most interested in gaining glide at the site of the injury. So if the injury is distal to the CMC joint, okay, it's somewhere out of here, then moving the CMC joint gains you nothing, because you're not creating any glide more distally, right? So there is, again, the perfect example of not letting the first CMC joint move would now demand excursion of the FPL across the joints where it needs the motion most. And I'm not saying I wouldn't say to that patient, can you touch the base of your little finger? You know, I might just in casual do that. But the problem for that patient with the FPL injury is not touching the base of the little finger. The problem is regaining the motion where it's needed. I was particularly referencing anyone with CMC osteoarthritis. I would not focus on that at all. And I've been thinking, you know, I don't know, I'll give you this, I think this afternoon or tomorrow, I can't remember. But we write a monthly newsletter that's clinical. And with each newsletter, we have either a clinical clue or a clinical pearl. And I've been thinking about writing one because I'm getting older now. And the exercise that I do to maintain my hands, I thought I would explain it. And it's this. And why do I do that? Because we'll talk about that tomorrow. But the thumb, I'm bringing out the, you may not appreciate this, I am bringing out the CMC joint as far as it will go. And it looks like I'm very adducted, doesn't it? But I only moved my MP joint just then. I did not move my CMC joint. Did I? And yet I'm all the way out here. So I want just my CMC joint to extend and abduct to its maximum. That's what I want to maintain the ability to do. I like to bring everything down to a very simple way of thinking. Why is an arthroplasty done on a CMC joint to recreate stability, right? The joint has lost stability. So the goal of the surgery is stability. Where I get really confused is surgeons and therapists who then both want and expect full normal range of motion. What is the point of that? If your goal is stability, don't you want stable mid-range? That would be the perfect example when I would not do this. What's the point in this? What does this gain? Okay. I want for that patient a thumb that is non-painful, stable, and functional. And to me, what that means postoperatively is figuring out what their muscle balance is and what new muscle balance they need in the mid-range to be stable. And I probably want to protect them from going to the end range in all directions, but particularly that flexion direction. And it's as simple as that. Protecting while the capsule's healing so they don't go to end range, and giving them the ability to transmit force in a stable posture. And to me, it's irrelevant whether it's an arthroplasty, resection, or an implant. It's still the same basic concept of wanting to stay in the mid-range and wanting good muscle stability. It's no different. I just don't see how it changes. There's not that much nuance to the different implants that you have to do something greatly different. But our disadvantage is that we often don't see patients prior to that surgery. And to me, that's a huge disadvantage because I want to see how they're moving, because that really helps me know what I need to really focus on with them post-op. But that'll come back to surface as they start their rehab, because that's what's dominant still in their cortex. Can I say I really don't know?
But you understand the...
Yeah. Well, it's sort of like I spent a lot of time delving into what the interosseous muscles of the finger do. And it's an absolute quandary to me because they can do one thing while they also are elongating. Now, how is that possible? I really, truly don't understand that. I think there's a level that we have not reached yet in our understanding of how muscles really work. And maybe there's even, the ability of a group of fibers to work independently while others are relaxed. I don't know. I honestly don't know. But, and I'm sad I'm at the end of my career because I would like to know. So that's your job now.
Thanks.
Okay.